Emergencies, obviously everything I say is from students, so I'll obviously ask questions at the end and we can go through anything that you're not sure on. I've basically sort of done this as like cases, so we're going to go through a case and then I'm going to use the chat to ask you guys what you think it is, and then we're going to just go through the condition, and it's very limited in the terms of the fact that I'm literally going through what I think you need to know for like an exam, because that's always how I sort of learn for my finals and things. So it will be quite exam focused. If you want to do like further reading, these are the things that I think are like the most important diseases to be familiar with going into finals. So we're going to start, I've split it into respiratory and cardio emergencies because I just don't really think there's any point in going between the two. So in terms of respiratory emergencies, so obviously it's really important to assess, properly understand how to assess an airway and breathing, because in like the A2E assessment, they are the like first two things. And like in a child, it is quite different because like the observations change based off their age. So like their respirate obviously is quite fast when they're first born, and it gets sort of slower as you get older. And by the time you're at about 12, it's sort of similar to adult values. So that's just something to be aware of when you're looking at observations, especially in children. In terms of like looking at the sort of breathing, things to be aware of. So you can look, these are things you can look for. So you can look at the chest expansion, auscultation. If you're looking to see if it's reduced on one side, if it's asymmetrical, any bronchial breath sounds. If they had a silent chest, that's quite concerning because it means they're not getting any air into their lungs. Looking at their sats on their pulse oximetry, obviously it's a good marker of oxygenation of the cells. And then CO2 monitoring as well can be done, but that's not really something that's done in A&E. Like I think that's more sort of like ITU. Once the ITU people have come down, it's not very accurate in like terms of the things that unless someone's on ventilation, it's not very accurate. Obviously you're looking at their respirate, looking for any recession. So that's where the sort of like skin is pulled in because there's not, the lungs haven't got enough oxygen. Any noises, grunting, use of accessory muscles. So like in young infants, it will be their tummy. So their tummy will be really coming in and out when they're breathing. Flaring of their nostrils, that shows that they're really, really trying to get breath in as well. So that's another thing to be looking out for. And gasping. So these are all signs of respiratory distress in an infant and things to be quite concerned about. So if you saw a child with one of them things, you'd be thinking about whether or not you needed to bring them into hospital if you saw them in like a GP practice or something. So the first case, we've got an 18-month-old baby. They've presented with a 2-day history of fever and they've developed a barking cough this morning. They've got no past medical history and they're allergic to penicillin. Do people want to pop in the chat what they think it is? I'll just get the chat up now. I mean, yeah, it looks like everyone's sort of got the idea. It is croup. It is that classic barking cough. They often have a couple of days of fever before and the parents will sort of be like, we've been giving them Calpol, it's just not been getting better, and then they've got this really bad cough this morning. So I'll just go through a bit about croup now. So croup is actually called acute laryngotracheal bronchitis. You should probably know that because I'm pretty sure that came up in one of my exams one year and they called it that instead of croup, so just being aware of that. It's most commonly caused by parainfluenza viruses, and as I said, the most common is a barking cough. They can get a stridor, so that's an inspiratory wheeze, and they can often be quite hoarse. So like if they are speaking, they'll be like, so obviously it's more common in quite young children, but if they are speaking, it will be sort of hoarser, and their voice, because it's affecting that sort of like their voice box and things. Usually preceded by a fever and sort of coryzal symptoms, so like a runny nose, a little bit bunged up, sort of an upper respiratory tract infection for the last couple of days. And it's really important that when you examine this child, you keep them calm. It's not as important as it is in something that we're going to talk about later, but it is important that you do keep them calm. You can assess the severity using the Wesley Croup score. I've not put it on here, but if you want to have a look at it in your own time, it just sort of goes through like the different severities and the treatment. So children get dexamethasone in GP. If they come in with it, everyone will get dex. If in A&E, quite often they'll give them an inhaled budesonide neb as well, and I've seen them done and used quite a few times as well. So these are more for the more severe sort of croup cases. So like obviously if you have a look at this croup severity, if they've got no stridor, they've got no recession, they're probably just going to be seen by their GP, given some dexamethasone and sent home. However, as it gets more severe, when you're getting down to sort of here, they might be a bit agitated, they might be a bit lethargic, they might have some recession, they could have a bit of a stridor. You're just a little bit more concerned about them sort of kids. So you'd probably give them a nebulizer and see how they got on. Obviously, once they're at this point, you need to be getting in contact with like ITU and the anaesthetist, because these children their airways are quite vulnerable. And you need to be like, you know, concerned about them kids. That's not something that you would like leave. You'd need to be quickly escalating that. So yeah, just to summarize, croup, the things that I would be really comfortable with is the fact that it's most commonly caused by parainfluenza viruses, the barking cough, and then the management. I would say they're the things that are like quite often buzzwords in exams. So just being aware of them. So that's just sort of a summary of croup. We'll move on to the next case now. So the second case is a 9-month-old baby. They've had coryzal symptoms for the past 5 days. They've come in because they've got a dry cough, they're short of breath, they've got feeding difficulties, and they've got a wheeze. They're all up to date with their vaccinations. And has anyone got any ideas what this could be? Look in the chat, sorry. Yeah, good. So this is a kind of more typical of a bronchiolitis picture. I'll just go through why now. Sort of the things that you're looking at in this, it's a 9-month-old baby. It's quite common in that sort of age group, sort of around the 12-month mark. They often, again, it's quite similar to croup in that sense. They'll have coryzal symptoms for 5 days. These kids will often be quite breathless and quite wheezy. So when you listen to their chest, you can really hear quite a distinct wheeze. And it comes on quite suddenly. Like I've seen quite a few kids with it, especially in the winter, it's quite common. And they really are struggling for breath. They're using them accessory muscles. And the feeding difficulties is often quite common with these kids, and that's often a reason for admission, because they're not feeding because they're so breathless that they just don't want, they need to be breathing. And then because they're not feeding, like that's obviously quite dangerous. So that's a reason. That's one of the like buzzwords of, if you see that, you need to admit that child until they're able to feed. Okay, so a little bit about bronchiolitis. So it's the most common serious respiratory tract infection in infants under the age of 1. 10% of kids are affected by it. 2 or 3% are admitted to hospital. So as I say, it's quite like relative to how common it is quite common that you'll see kids with this in the winter. As I said, common in the winter, most commonly caused by RSV. That's the pathogen you're looking at before the virus. Definitely be aware of that. That's a common like kind of exam-y sort of question. So yeah, features, you get a fever, you can get coryzal symptoms the first couple of days. That's really common. You'll see kids with that quite a lot. They'll have a dry cough. It'll be like kind of, they won't be bringing anything up, and it will sound quite dry, and they'll be quite short of breath. The thing that's kind of differentiates this child is that they are quite wheezy. So an infant that's wheezy, you're thinking bronchiolitis, basically. Sometimes you can get fine end inspiratory crackles, but that's quite hard to distinguish. So I would say the thing to be aware of is a wheeze. In terms of investigations, you can do nasopharyngeal secretions to confirm that it's RSV. Usually these kids are just diagnosed based off symptoms. I've not seen nasopharyngeal secretions actually be done, I don't think. So just being aware that usually they're just, I mean, obviously in an exam setting, you could say that, but in terms of clinical practice, that's not as common. Blood gases are done in severe cases, but I've not seen them used unless that child is in severe respiratory distress. I've not seen them used because they're quite painful. You don't really want to be doing that in a child unless you absolutely have to, unless it's going to change your management. So that would be something that ITU would be doing, or anaesthetics, so you won't need to be aware of that. In terms of management, it is just supportive management. So fluids, O2, I have seen them given nebs in hospital, so salbutamol nebs. It's not actually in, if you like in textbooks and things, it's not really there, but that is something that sort of anecdotally I've seen used. But just in terms of care, it is mostly just supportive. So fluids, oxygen, if their SATs are low, and then just making sure they're feeding, making sure they're wetting their nappies. You need to be aware of them sort of things when you're looking at children, because they're so important. Like if you can't discharge a child home if they're not feeding properly. So you need to be like, when you're, that's why it's quite a difficult one in terms of admitting a child with this sort of thing, because as an infant they're obviously still on bottles and just weaning onto food, so you wouldn't want to be sending them home hoping that they'd be able to get a little bit down, because especially where they can't communicate, it's just a bit more tricky. So yeah, that's just a little bit about bronchiolitis, things I would be aware of. I've kind of highlighted there, because they're the things that I think come up in exams, knowing the age, knowing the winter months, RSV, the type of symptoms you're going to get, and knowing that what sort of would trigger you to admit them. So things like if they're not feeding, if they look like they're struggling to breathe, so they've got nasal flaring, they've got that recession, they're using their accessory muscles, they're the things that I'd be aware of for admission. Okay. Oh, here we go. I actually made a slide on this. Sorry. So reasons for admission are poor feeding, respirate over 60. Obviously, that's quite difficult because children vary, but as a baby, their respirate's meant to be like, I think it's around 40. I could be wrong on that. I'll double check. I don't want to give you false information. Oh yeah, 25 to 50. Going down to 25 to, yeah, about 20 to 40. 20 to 40 in this age group. So if it's over 60, that's quite concerning. And then low SATs. You can get apnea in premature babies. It's just where they stop breathing. Obviously very scary for the parents. So like you need to be aware of that, because you don't want to send a child home that's at risk of that. So being aware of their sort of like birthing history and things is so important. And these are the risk factors for severity. So if they're less than 6 weeks, if they're premature, if they've got chronic lung disease or congenital lung disease or congenital heart disease, or if they've got any immunodeficiency disorders, you'd want to be kind of mindful of sending them kids home in case of deterioration, or if you are going to send them home with very effective safety netting of when to come back, because you don't want to be discharging a child for them to just get really poorly while they're at home and they've got no one to help them. Okay, so in terms of case 3, this is a 6-year-old boy. He has come in with shortness of breath and cyanosis. He has had a dry cough at night for the last couple of months. Mum's not really thought much of it. He's got a history of eczema, and he had bronchiolitis quite a lot as a child. Does anyone have any ideas on what this one could be? Fab. So the people that are going along the asthma are right. Viral-induced wheeze is more common in young children. I say probably like before they're diagnosed with asthma, so like 3 would be something that I'd say would be more being aware of, like that sort of the distinguishing thing. And then yeah, asthma, it is correct. All right, then we'll go on to the next slide. Sorry, let me just close the chat. Okay, so asthma, obviously a very important disease. You need to be quite familiar with this for your exams. It comes up every year. It will always be there. So it is a chronic inflammatory disorder of the airways. Risk factors, so history of ATP, so eczema or hay fever. So it's like a triad of ATP, so asthma, eczema and hay fever. If you have one, you're more likely to get the other 2. In terms of antenatal factors, if the mother smoked, then that makes you at a higher risk for asthma. If they had a viral infection during pregnancy, in particular RSV, if they were of a low birth weight, if they weren't breastfed, maternal smoking around the child, or paternal family smoking around the child makes the child increase risk of asthma. Exposure to high concentrations of allergens, so dust mites, if they've got an atopy sort of thing, and then pollution is like a risk factor, not really one that I would be like super familiar with. I think the one to be most comfortable with is the fact that there is this triad of atopy, and then the antenatal factors. So symptoms, they often have a cough and it's often worse at night. So that was basically my little hint that that's what it was. They get coughs in the night, shortness of breath, they get a wheeze and they feel like their chest is really tight, can't take a deep breath in. Sometimes they get a bit of pain in the chest as well. So when you're examining them, you're listening for a wheeze, and it's pretty obvious. You'll be able to hear it, especially if it's severe enough that they've taken them to A&E. And then they will have a reduced peak expiratory flow rate. If you do them the peak flow, it is done. But just, yeah, they're the things that would happen. So in terms of the severity, it varies based off whether they're between the ages of 2 and 5. Very uncommon to get asthma in a child of that age, though. Usually you wouldn't really diagnose a child with asthma until they were over the age of 5. So this is probably more relevant to sort of viral-induced wheeze and things. But in children over 5, SATs over 92 is a moderate attack, and then their peak flow being greater than 50. No features of severe. So basically, you don't really need to know anything about moderate, apart from the fact that it's greater than 50. Severe is less than 92. 33 to 50 of best or predicted. Can't speak in full sentences or can't feed or talk. Heart rate over 125, respirate over 30, and use of accessory neck muscles. And then life-threatening, they'll have a silent chest. That's really important to be aware of. If a child has a silent chest, you need to be escalating that like rapid, because that's really dangerous. And a poor respiratory effort. So these kids will really try to breathe and then they'll fatigue, and that's when they'll stop trying. They'll get tired, they'll be cynosed, they won't really be trying, and they'll just not, their respiratory effort will really diminish, and you'll see it, and they'll have a silent chest. If they get that, obviously escalate this child very rapidly. In terms of management, oxygen, if they're SATs are less than 94%, salbutamol, you can either give this through a nebulizer or a spacer. In A&E, they will probably give it through a nebulizer, unless the child is not happy to have a mask on their face and is really kicking up a fuss. I know they say using a close-fitting mask, but you can use a spacer if the child's comfortable with that. A puff every 30 to 60 seconds, up to a maximum of 10 puffs. If they're not controlled, repeat and return to hospital. So obviously this is the advice you would give as a GP or a parent. Then you'd also add in ipratropium nebs if they're in hospital. So most times if they come in with asthma, they'll be given salbutamol and ipratropium nebs straight away. And then steroid therapy is given for 5 days is the NICE guideline, following an asthma attack. So if they are in the community, they'll be given oral prednisolone, take it home, take it every day, 5 days, fine. If they're in A&E, they'll be given IV hydrocortisone and then probably step down to pred once they're sort of stabilised. And that should be given to every child that has an asthma exacerbation. So that's just something to be aware of in terms of the management. I'd be really comfortable with that. Acute management of asthma. Make sure that you know what you're talking about in terms of that. There is further things that you can do as you escalate up. So like once you can give them like magnesium and theophylline, aminophylline and things, but I've not really seen that used by A&E staff. It's more commonly once they've sort of escalated it up to someone else and they've said we think they need that. Obviously I'm not put that in today, but you guys need to also be quite familiar with the stepwise management of asthma in kids and adults. There's loads of it on the internet, PassMed, wherever you look, it's everywhere. So just being aware that you should probably be familiar with that as well. That's not in terms of an acute emergency, which is why I've not put it in today, but in terms of just management of asthma and control. Okay, so we're going to move on to case 4 now. So this is a 5-year-old girl. She's got a high temperature. She's quite unwell. She's drooling and she's leant forward. Her mum is an anti-vaxxer. Anyone like to tell me what they think this is? Yeah. Anyone want to put anything else in? Fab. I think the people that are saying epiglottitis have got where I'm coming from with this one. So this is a typical epiglottitis picture. It's not actually very commonly seen anymore because of the vaccination program. So in the question, in an exam, sorry, I always talk in an exams setting, it will have something along the lines of either their parents are anti-vaxxers, they've just moved to the country and they've had none of their immunisations, or they're just not up to date on their IMS. So just being aware that if you see that, just think, oh, that means that they've got a disease that is caused by something that we actually immunise against. So it kind of gives you that hint. These kids will have a really high temperature. They'll look quite poorly. They're often drooling because their airway is quite compromised, and they're leant forward in that sort of tripoding position just to get more air into their lungs. So their heads forward and their hands are on they're leant forward like that. So just a little bit about acute epiglottitis. So it's caused by Haemophilus influenza type B. So HIB, like in exam, whatever. Sometimes it could be shortened to. It's essential because you need to recognise and treat this really quickly, because airway obstruction is like critical. So it happens really fast. They have, as I said, high temperature, really unwell. They'll have a stridor, so that's an inspiratory wheeze, and you'll be able to hear it. They'll have a drooling of saliva, and they'll be in that tripod position, as I said. So if you think you have a child and you think they've got epiglottitis, don't examine them, don't go near them. Call anaesthetics or ITU, someone that is comfortable with airways, because if you agitate this child in any way, their airway is more likely to close. And if that happens, they're going to go like straight. So you need to have someone there that is comfortable with airways, comfortable with children, and who can examine that child properly. So yeah, as it says, immediate senior involvement is, if you see epiglottitis and they say what's your management, you're going to get your senior. Like you don't try and manage this yourself. You need anaesthetics, ENT as well, and other people you can call. You might need to intubate them to protect the airway, and you might need to give them oxygen because their airway is so obstructed that they might just not be oxygenating well enough. You can give them IV cefuroxime. That's the management. But I would say the thing to be most comfortable with is the fact that you need to get a senior involved ASAP, and knowing the signs, because you wouldn't really need to manage this yourself until you're an adult. Yeah. Okay then. All right then. So that's basically run through of respiratory emergencies. Should we just do questions for that now, and then we can just move on? Yeah, I wouldn't take a rectal temperature in a child that has, to be honest, I would be reluctant to even take a ear temperature in a child that has epiglottitis. I would probably do one of the I mean, I don't know in my department, they just have one of the ones that you just scan like on their head. I would only do that kind of a temperature in that kind of a child, because even an ear temperature makes kids cry. So you want to be really careful. I know someone's just asked me separately, but if asthma wheeze only occurs on expiration, wheeze is only on expiration. So if it's an inspiratory wheeze and it's a stridor, they're two separate things. Anyone got any other questions? No. Cool. Oh god. I can't close this. 1 second. Okay, so the way that I've approached this is quite brief. I've split this, so I'm not going to go through any of the acyanotic congenital heart disease. That's something for you guys to look through in your own time. That's not an emergency. Them kids often aren't picked up until they've got to the point that they've developed Eisenmengers, which is something that I'm going to go through in a little bit more detail. So tetralogy of Fallot is more common than transposition of the great arteries. However, it presents a little bit later, whereas this is always at birth. So I'm going to go through what they both are. These things you need to be familiar with for your exams, but they aren't emergencies. And these kids often go about normal life until they get a little bit older, sometimes forever. Like 1 in 4 people have a VSD or something. So I wouldn't be too concerned about them kids. So in terms of tetralogy of Fallot, they present at about 1 to 2 months, as I said. They have 4 key features that you need to be aware of, and you need to really know these because this is a favourite of examiners to ask. So they'll have a VSD, they'll have right ventricular hypertrophy, they'll have a right ventricular so they'll have pulmonary stenosis. So they'll have a right ventricular outflow tract obstruction in this format of pulmonary stenosis. And they'll have an overriding aorta, so their aorta will kind of come out of their right ventricle. Features, they can get cyanosed. It causes a right to left shunt because the blood, it's because of this ventricular hypertrophy, and then you've got that stenosis. The blood has nowhere else to go apart from to the left side of the heart, so it gets pushed over to the left, and then that deoxygenated blood is sent into the rest of the body. So that blood's not been to the lungs yet because the pulmonary stenosis, along with the ventricular hypertrophy, means the pressure is higher on that side than it is on the left side. So it pushes blood from the right-hand side to the left-hand side. They'll have an ejection systolic murmur. The reason that these kids sometimes don't present for a little while is because the blood can be oxygenated for, so at the start, when they're first born, their stenosis, like there's still some blood getting oxygenated, so they're not going to be ridiculous. They're going to have a left to right shunt at the start, and then it very quickly becomes a right to left. Chest X-ray, right-sided aortic arch is seen in 25% of these patients. Chest X-ray shows a boot-shaped heart. That's something to be aware of. ECG will show right ventricular hypertrophy, which can come as like right axis deviation. So that's something for ECG interpretation. But yeah, right axis deviation is shown. It will happen in right ventricular hypertrophy. They can be repaired surgically, often in 2 parts. They can get given beta blockers to reduce infundibular spasm for their cyanotic episodes. And these kids need to be operated on quite quickly. And they're often quite poorly. So I think I've seen one of these. I saw it, it was in ITU. So just being aware that these kids will be sick. And in terms of an exam, the things I would say you need to be aware of are the features in terms of these 4 things. You need to be really familiar with them. And this stuff, like the boot-shaped heart and the fact they can have an ejection systolic murmur. They're probably the few things that I would say are like exam buzzwords to write down. So yeah, that's just one of the cyanotic congenital heart diseases. And then there's transposition of the great arteries. This is just something that happens when basically the aorta leaves the right ventricle and the pulmonary trunk leaves the left ventricle. So there is no oxygenation of the blood because the blood just goes. So the aorta, which goes to the rest of the body, comes out of the right side of the heart where it's not been oxygenated. So these kids are born and have no oxygenation. So they are big sick, very poorly, will need immediate ICU and cardiac surgery. This picture, I think, is like, if you really look at this picture, like take some time to understand what it actually means, because it's not something that I think is very well explained, but it's quite easy to visualize because you're seeing like the deoxygenated blood just keeps going around their body, and the oxygenated blood just keeps going around their lungs and getting more and more oxygenated. So these kids are cyanosed. They'll be often quite short of breath because they're not getting any oxygen. They'll have a loud single S2, a prominent right ventricular impulse, and the chest X-ray appearance that they love in an exam is an egg on side appearance. Don't know why it looks like that, but it does. So managing these, you need to keep the ductus arteriosus open with prostaglandins, because that is the only opportunity the blood has to mix. So the ductus arteriosus is here. You can probably see it. Like, so it's basically, it links the, you can't see it on this picture. It links the aorta and the pulmonary artery. So that will allow some mixing of the oxygenated and deoxygenated blood. So you'll get some oxygenated blood around the body. And when you're born, it closes because it's used in fetal circulation. And when you're born, it closes, but prostaglandins stop that from happening. So it's like, it basically links the aorta and the pulmonary artery, and it just becomes like a tendon as you become an adult. But when you're young, when you're in utero, it allows mixing of the blood. So that's what you basically do. You give them prostaglandins until you can get them to surgery. It's like a 4-stage surgery. It's really long, if I remember rightly from what I got told. But it's surgical correction is basically all you can do. Not all of these kids will survive because you need to literally operate on them straight away. And they're very, very poorly. So they're the things to be aware of. What it is, the fact they're going to often be cyanosed, egg on side. You need to give them prostaglandins, surgery. Okay, so Eisenmenger's is the thing that happens in cyanotic defects. And basically what it is when you have a cyanotic defect, you have a left to right shunt. So the oxygenated blood is just going over to the right side of the heart to be to where the deoxygenated blood to go back to the lungs to be reoxygenated, but it's not enough because the pressures are higher on the left side. It's not enough blood not going through that little hole to through the VSD or the ASD or the PDA to cause problems. The issue arises because that extra blood going through means that the pressure in the right side of the heart gets higher, because you're increasing the blood flow through the right side of the heart. And because that happens, the right side of the heart gets hypertrophied, and you get pulmonary hypertension because there's too much blood going through the pulmonary arteries and the capillaries of the lungs. So you get pulmonary hypertension, and when you get pulmonary hypertension and ventricular hypertrophy, the right side of the heart gets stronger and stronger and stronger, and to the point that it causes a right to left shunt. And once it causes a right to left shunt, that deoxygenated blood is going now straight out without being oxygenated. So it's going straight into the body without being oxygenated. So that's where you're going to run into issues, because when it's the left to right shunt, the blood is just being reoxygenated. It doesn't really make a difference. But once it goes the other way, the deoxygenated blood's going out to the body without going through the lungs, so it's not got any oxygen in it, basically. And these kids will start to get like kind of cyanosed. They sometimes have clubbing on their fingers, and they'll just sort of be a bit poorly. Like they might keep getting kind of like respiratory infections, and mum's a bit concerned, doesn't really know what's going on. And then you'll listen, and they'll often have a murmur. That's sort of in the lead up. Once they get Eisenmenger's, they'll be cyanosed and clubbing. Right ventricular failure, they're really poorly. But in the lead up to Eisenmenger's, whilst it is slowly reversing, they'll start to get more breathless when they're exerting themselves, and sometimes they'll get cyanosed when they're exerting themselves, and then they might sort of get more infections and things like that. Managing Eisenmenger's is a heart-lung transplant, because their lungs have got the pulmonary vasculature's destroyed, and the heart is all wrong as well, because they've got right ventricular hypertrophy left. So it's just basically the only management is heart-lung transplant. So this is really serious, and that's why we do treat congenital non-cyanotic. Sorry, I meant to say acyanotic, but that's why we treat them, because we don't want it to progress to this. Yeah, and that is everything I have for you. Sorry, it's quite short. Has anyone got any questions? I know that the cardiac stuff is quite confusing. Like, I think that that's something that does take a little while to get your head around. So that's just, I know someone just asked me, why is there right ventricular hypertrophy when the stenosed pulmonary artery originates from the left ventricle? That's just because the stenosed pulmonary artery doesn't originate from the left ventricle, it originates from the right. Because the pulmonary artery comes from the right ventricle and the aorta comes from the left. Yeah, then there'll be cyanosis in previously acyanotic disease, correct. Why is there corrective surgery should be done by the age of 3 to 11? Thank you. People are asking each other's questions. Yeah, does anyone have any other questions? If not, thank you very much. That's everything I have for you. I hope that was helpful.